what causes hypertension in nephritic syndrome? Why do you get
Damage to nephrons.
you get damage to nephrons, but again, same scenario, right? If you're having nephritic syndrome, a lot of those conditions will still end up having some level of proteinuria because you do transmit and cause damage to the podocytes. So if you lose fluid because proteinuria and you lose protein, right, you become intravascular depleted. If you intravascularly deplete because your albumin is low and your oncotic pressure is low, you activate RAS. Once you activate RAS, you got hypertension. Not just because you reabsorb sodium and water and reabsorb free water because of ADH, right? You also activate your aldosterone, but you actually cause sympathetic vasoconstriction, right? And therefore you're going to raise blood pressure. When should RAS blockers be used in patients with nephritic syndrome? Is it dependent on proteinuria? So you want to use it if there's proteinuria. Remember, nephritic syndrome is primarily not a nephrotic problem, right? In nephritic, it's more to do with hematuria and producing RBC Cas. But you can have some proteinuria. So if you're having proteinuria greater than 0.5 grams per day, okay? If you're going more than 0.5 grams of proteinuria per day, then you'll start them on a RAS blocker, such as ACE inhibitor or ARBs. Most of your nephrotic syndrome patients, do they straight up get RAS blockers? Yes, because they're having nephrotic range proteinuria, right? And you want to drop their proteinuria. So therefore, nephrotic syndrome, you know to start a RAS blocker anyways. Nephritic syndrome is not the case because it's more to do with not proteinuria, but you should think that, hey, if there is some proteinuria, more than 0.5 grams per day, then you need to consider starting them on a RAS blocker. Yeah?